Thanks a lot to the organizers for giving me this opportunity. It's always lovely to be back in Kolkata. And thank you, sir. Thank you for the very kind introduction. And it's very nice and it's a pleasure to be here and be with you seniors. So, my talk today is going to be more of a conceptual talk because you will see a lot of action in the presentations going forward. You have seen a lot of information being delivered to you in the two talks before my talk. So basically I will just talk about the collateral system of the brain and how exactly this collateral system behaves when it is presented with a situation when blood cannot reach a particular area due to some circumstances. So before we go into the collateral system per se, it is always good to look back. And the first description of an anastomotic pathway existing at the base of the brain, the so-called arteria anastomotica magna, was given by Thomas Willis in 1664. This is his monograph. This book is his monograph. This is actually not just on the brain. It is a 1,200 page textbook, out of which around 40 to 50 pages only are dedicated to the nervous system. This is a book on the entire human anatomy, and in that one part of the book is dedicated to the blood circulation of the brain, and this is the part in which for the first time he described the presence of an anastomotic circle at the base of the brain. The significance of the circle obviously was not known at that time, and honestly speaking, even 500 years down the line, we have not been able to understand the exact benefits that this circle provides to us. So we will try and spend the next 35 to 40 minutes in trying to look at cases and see how exactly nature uses this particular information for trying to perfuse the brain in situations in which the brain is subjected to a condition of hypoperfusion. We now have the techniques and the technologies to assess the circulation of the brain in multiple techniques. We have already seen many of those in the previous talks. So basically, whenever we talk about perfusion of the brain, you have blood which is exiting from below, from the cardiac level, through the great arteries. And through the great arteries, you have the four main conduits, the two common carotid arteries and the two vertebral arteries. These are the vessels which carry the oxygenated blood from the cardiac level up to the brain. At the base of the brain, you have the arteria anastomotica magna, where these four vessels meet in different configurations in different individuals. And from there, they are distributed to the rest of the cerebral hemispheres and to the brainstem. Now, whenever we talk about the circle of Willis and whenever we talk about the concept of collateralization, we should understand that the collateralization, nature has provided collateralization in the form of circle of Willis, which is the so-called Willisian level, from which you have, even if you have three inputs occluded, one remaining input is enough to sustain the entire circulation. So that is the most common one that we are already aware of. You also have situations in which you can develop collaterals proximal to the circle of Willis. These are collaterals which can be embryological, or these are collaterals which are present in very small forms in all of us, and they can get opened up in situations when there is a chronic ischemic process, and we will look into that. And finally, even on the top, once you have the vessels, once you have the anterior cerebral artery, the middle cerebral artery, the posterior cerebral artery, the lenticulostriates and the choroidals, just like we saw in the previous case example, you had a situation in which the MCA was occluded. But even when the MCA was occluded, the lenticulostriate arteries in that particular case went beyond their mandate, and they went from the phylogenetic circle upwards, and they started supplying the telencephalon, which is not their mandate. But the moment the telencephalic supply was restored, they again came back immediately on the table. So what we have to understand is, when we talk about collateral circulation in the brain, we usually just talk about the collateral circulation at the base of the brain, the circle of Willis, but we have a lot of potential opportunities present even below the circle of Willis as well as above the circle of Willis. So we will look at all these three situations in this talk. Let me show you an example. I'll show you this case. This is the case of a young male. I'm sorry, I have not anonymized his name. This is a young male. He is around 16 years old, and he came to us with simple problem. He just came to us with headache. The description of the headache was like any other vascular headache that you might see on a given OPD day. And we just got a simple CT scan done, got some simple blood tests done. Vitamin D was low. We put him on flunarizine. We sent him home. He comes back again after a week or two saying that he is not benefiting, he is not improving. So what do? We do the imaging further. We this time ask for a MR imaging, and in our institute the protocol is whenever we do an MR, we do a complete MR. We just don't do an MR of the brain. We do the arteries, we do the veins, and we do a contrast study, because very often you will miss out if you don't do the whole thing. So we were not expecting anything. We sent this patient for an MR, and my technician just calls me and says that, sir, the vessels on top are looking good, because that is what he's been trained to look for, because we do a lot of international cases. So whenever we ask for a post-procedure MR, he tends to look at these vessels, thinking that something might have gotten occluded during the intervention. But he says at the same time that, sir, at the bottom I see only two. I don't see the other two vessels. So I tell him, okay, fine, I'll take a look at it. And then when we look at it very carefully, we find that this is a situation in which the supravilician arcade is very well maintained. This is a 1.5 PMR. On a 1.5 PMR, a short 3-minute sequence, a top sequence, we can see that the perfusion of the brain is great. There is no problem in the perfusion. The venous system was completely normal. There was no problem in that as well. But as the technician said correctly, when we look at the bottom, we see that there are only two vessels. So these two are the vertebrae. So basically, in essence, this patient is surviving on two vertebral arteries, just two vertebral arteries. When we do the lateral, we find that yes, we have the two vertebral arteries, we have the basilar artery, then we have the posterior communicating arteries on both sides, and these posterior communicating arteries on both sides are giving rise to the MCA-ACA complex, and the supravilician part is absolutely intact. As far as the vilician and infravilician part goes, we see in this case that the carotids, both the internal carotids, mind you, this is not a complete absence of the common carotids, because if you see carefully, you have a very robust superficial temporal artery on both sides, you have a very robust middle mental artery on both sides, you have a very robust internal maxillary artery and its discality on both sides. So basically, this is a situation in which both the internal carotid arteries are not visualized from the neck upwards. So we tend to think of it as either it might be congenital or it might be acquired. To answer that question, we do a skull-based CT, and we find this is from above, this is the calvarium that has been removed, and this is from below. When we look at it from above, we see that the foramen rotundum, ovale and spinosum, these three are very well seen. But if you try and hunt for the carotid canal, obviously this is not the view for the carotid canal, but if you at least want to look at the lacerum, you find that the lacerum does not seem to be very well developed. And when we look at the bottom, we find that the carotid canals are missing from both sides. So now this is a very rare example of a situation in which both the internal carotid arteries are not present, both the external carotid arteries are present, both the vertebral arteries are present, and the carotid canal has not developed, meaning that this is a congenital agenesis of the internal carotid arteries. And based on the anastomotic circle, the circle of Willis, the discality of the cerebral perfusion is being maintained by the robustness of the posterior to anterior communication of the circle of Willis and thereafter. There is an interesting point here. We keep on teaching in our embryological lectures that internal carotid artery has basically two parts. The internal carotid artery divides into a cranial division and a rostral division. The rostral division or the posterior division or the caudal division is the one which forms the PCOM and subsequently a part of the PCA. It also comes down up to the level of the ICA. So actually what we teach embryologically is that supposing the ICA is somewhere here, up to the ICA territory, the basilar artery, the PCA and the PCOMs are because of the fusion, caudal fusion of the ICA. Now the question in this case is, there's no ICA. So when there's no ICA, how did this get formed? We will try and answer that after these cases if we have some more time. In this case, what basically happened is, embryologically, we know that we have, our brain has got a part of the Piscean brain, the fish brain, the amphibian brain, in between a reptilian brain, then a paleomammalian brain, a mammalian brain, and then subsequently our brain. So we have these 5 steps. What we have to understand is, when we look at this phylogenetic evolution, in the stage 1, in the Piscean brain, in the fish brain, the carotid arteries are almost non-existent. The circulation is almost entire from the basilar to the pecom and then to the telencephalic areas, because the telencephalon is not very well developed. When we come to stage 2, that is in the amphibian brain, basically again you have the basilar to pecom to just the anterior brain, that is the renencephalon, that is the ACA territory. The rest of the MCA territory is going to be perfused by the ICA. And then subsequently, when we come to the mammals, after 2 more steps, what we realize is, at this level, since the forebrain has grown to quite an extent, you have a carotid dominance, and then in that situation, you have a reversal of the flow from the carotids to the pecoms and to the vertebrobasilar system. What has happened in our case, what has happened in this particular case is, we have gone back, instead of going forward in evolution, we have gone 2 steps back, and we have reached this situation in which we are seeing a posterior to anterior circulation. So this is how phylogenetically we explain all that. Let us look at another case. This is a very recent case. This was done just I think this is that is the 29th of March, just a week back. This is again a young patient. He is a 38-year-old patient. He has come to us with subarachnoid hemorrhage. His presentation was he had a thunderclap headache, he had vomiting, he had transient loss of consciousness, and then he was sent to us. When we examined him, we found a lot of abnormalities, especially between the 2 sides. As far as the pulses were concerned, we have made it a point to make sure that all our residents do this. And therefore, since we found that the pulses on the left side were weaker, we got an angiogram, a CT angiogram for this patient of the entire axis. We were contemplating an intervention, so we do transradial most often, but still there is no harm in trying to see what is the condition of the iliac arteries and the femoral arteries. So right from the femorals up to the brain, we did a CT angio, and we have some interesting findings in the CT angio. What I'll do is I'll just go to the magnified images. So this is an image of the arch and the lower part, the abdominal part, the thoraco-abdominal aorta, and this is a part of the arch from here onwards going up. First of all, when we look at the aorta in the abdomen and in the thorax, we find that there are areas of stenosis, there are areas of dilatation, and there is extensive neural calcification in the entire aortic arch. When we go to the arteries that concern us as neurointerventionists, we find a lot of interesting things. We find that it is a bovine configuration, a bovinoid configuration. The left common carotid is completely occluded right at the origin. The left subclavian is also completely occluded right at the origin. But when we go distally, we start seeing that the vertebral artery is also filling up. That is not a surprise, because you are having a very robust vertebral from the right side. So blood is going up via this, going up, and then from there coming down again. That was the explanation that we thought of. And you also have a situation in which the carotid, which is completely missing from here, you can start seeing that the carotid bulb is appearing there. So you have a situation in which on the left side, the subclavian is occluded, but the distal vertebral artery is okay, the distal subclavian artery is okay. You have a situation in which the left common carotid is completely occluded just at the origin. You can just see a stump. But as we go up, we start seeing that the carotid bulb is becoming visible. So this obviously means that despite there being no inflow into the two great arteries from the arch on the left side, either the circle of Willis, and not just the circle of Willis, some vessels below the circle of Willis in the infravillician area are also working hard to reform this entire circulation. Also, this patient has come to us with a subarachnoid hemorrhage. This patient has not come to us with an ischemic lesion. So we have to explain and account for that as well. So when we explore further, what we see in this patient, okay, we'll come back to this case after I show you a few more examples. Another case, moya-moya angiopathy. Moya-moya angiopathy, in which we are seeing this is the right ICA injection, this is the left ICA injection. If you look at the right hemisphere, the contribution from the right ICA is only patchy, to say at best. You have a PCOM which is continuing posteriorly, which is forming the posterior cerebral artery and is supplying the medial occipitotemporal gyrus. So the right ICA, let us concentrate only on the right hemisphere in this case for shortage of time. So in this case, the right hemisphere ICA, which was mandated to supply this entire hemisphere, is only supplying bits and pieces. This patient has come to us with an ischemic stroke, so there is definitely some problem in the circulation. When we do the vertebral injection, we do the left vertebral injection, we find that it is supplying the posterior fossa, but it is also supplying parts of the right hemisphere via the leptomeningeal collaterals as well as via the choroidal system from behind. And when we finally inject the external carotid system, what we find is the external carotid system super selective angiography shows you opacification of the inferior frontal gyrus, parts of the middle frontal gyrus, as well as the lateral occipitotemporal gyrus, the occipital lobe, as well as parts of the parietal lobe. Now this much area is being supplied by the external carotid artery. When we do a shoot of the internal carotid artery, we find that the area which is missing here from the center is being supplied by the internal carotid artery. And when we look at the vertebral injection, we find that whatever areas were missing from the posterior part of the parietal lobe as well as the superior temporal gyrus are being supplied by the vertebral artery. So in this case, what has basically happened is you have an inflow problem at the neck or at the supraclinoid ICA. To overcome that problem, you have leptomeningeal collaterals, which are supravilician collaterals, which are coming from behind, which are coming from the PCA, the PCOM PCA. And you have recruitment of the external carotid artery. The external carotid artery has got 8 branches, out of which we have 3 branches which are mucocutaneous. Mucocutaneous means they are segmental arteries. The internal maxillary is a segmental artery, the occipital is a segmental artery, and the ascending pharyngeal is a segmental artery. So these 3 vessels will ultimately be able to give branches which can anastomose with the intracranial circulation. And then ultimately, when we put all these 3 pictures together, we get a composite picture of the right hemispheric blood supply. So this is a situation. In the previous case, we saw that the compensation was predominantly infravilician. In this case, we see that the compensation is predominantly vilician, as well as to some extent supravilician. This is again from the same patient. This is a super selective angiographic exploration of just one perforated trunk originating from the ICA. This one perforated trunk, whose mandate was to supply an area which has been highlighted by the pointer. This is for all theoretical purposes the so-called phylogenetic circle. So the mandate of this perforator was to supply area only within this circle. But when there is chronic ischemia, when there is demand, you see that it has gone almost, or rather up to the cortical surface, and it is supplying the brain up to the cortical surface. So till now we saw that you can have collaterals at the infravilician level, you can have collaterals at the vilician level, you can have collaterals at the supravilician level. You can have situations in which the external carotid artery can reinforce all these 3 systems, and among the supravilician vessels, you have 2 territories. You have the deep territory or the perforator territory, and you have the superficial territory or the leptomeningeal territory, there can be cross flow and there can be anastomotic channels between these two as well. Same picture, we just skip this. Based on that concept, we have developed our models in which we try to explain how exactly does blood flow in a so-called normal brain, which is shown to you on the left-hand side panel, as well as in situations when you have chronic occlusions, let's say of the M1 segment. The M1 occlusion, as the case discussed before, could be an atherosclerotic occlusion or a secondary moya-moya, it can be a primary moya-moya, or it can be an embolic occlusion for all what is necessary. So what basically happens is, whenever you have blood entering into the brain, the blood, for example, let's talk only about the carotid system, the blood enters via the internal carotid artery. So in this condition, normal. In this condition in which, let us say, there is an occlusion very distal to the origin of the perforators, blood will still enter this system from below. From below it will come into the M1 segment. From the M1 segment, in the so-called normal predisposition, the blood will be sent to the leptomeningeal system. The leptomeningeal system is a system of sulci and gyri, and these systems are filled up with branches from the MCA or the ACA or the PCA. Whereas in case of so-called moya-moya, in this case, the distality is almost completely occluded because there is a progressive failure or a steno-occlusive disease of the ICA-MCA complex. So how does the blood ascend in this situation? Instead of going to the leptomeningeal surface, it starts going via the lenticulostriate arteries, and these lenticulostriate arteries, which were supposed to supply only up to the ventricular edge, they become large, they become arborized, and then subsequently the blood that was supposed to reach the surface initially is now going through the brain, and this is a transcerebral circulatory model in which the blood, instead of going up and then coming down, is going deep inside and then going up to the surface. What happens then? Once the blood has reached the leptomeningeal system in the normal case, you have the deep medullary venous system. The deep medullary venous system ultimately has a transcerebral course. With the transcerebral course, it reaches the edge of the ventricle. Once it reaches the edge of the ventricle, from there it goes into the deep venous system and then it exits. Since in this situation, the blood is going from inside to outwards, the transcerebral flow has been reversed, and therefore in these situations, in chronic occlusions or in moya-moya, what is going to happen is the blood, instead of being drained via the deep venous system, in fact, whenever you see images like this, you will see the deep venous system very prominently. But if you look at this image, you can see that this is the ventricle. You can see that this is the outline of the ventricle here. You do not see the opacification of the deep venous system. It does not mean that the deep venous system is not there, it is there. But it is just not being opacified because the blood, instead of going from outside inwards, is now going from inside outwards, and therefore most of the blood in this situation is going to be exited via the cortical venous system. So the directionality of blood flow in normal is from outside inwards, whereas in chronic occlusive conditions, it is from inside outwards. This tells us a lot about the physiology and the pattern of oxygenation of the brain. We can discuss that at some other stage. Let us skip this. Let us go to some other case. Another case of moya-moya. Moya-moya in which we have done a super selective injection of just the external carotid artery. This injection has been done with a microcatheter, absolutely no reflux, absolutely no filling or no dye reflux into the internal carotid artery. Still we can see that the scalp arteries on the surface, the extracranial scalp arteries have become very prominent. These scalp arteries are ultimately looking for these diploic vessels. so that they can reinforce the diploic vessels, and these diploic vessels in turn can reinforce the middle meningeal system, which is a part of the internal maxillary artery, which is a mucocutaneous artery, and which by definition can supply the brain. So, lot of prominence of the external carotid branches, prominence of the diploic vessels, prominence of the middle meningeal system, and de novo middle meningeal system to leptomeningeal system anastomosis at the levels of the crown of the gyri, filling the arteries which are underfilled from below. So this is not just a supravilician collateral, this is a supravilician transcortical bone collateral. So these pathways also do exist and they can be tapped in individual cases. Again, a similar example from a different case. ICA, chronic steno-occlusive disease, same presentation, double antiplatelets, aspirin, clopidogrel, no response, continues to have AIS, then aspirin, ticagrelor, no response, continues to have AIS. But that is not important for this discussion. What is important is, if you look at the ophthalmic artery, you can see that the ophthalmic artery is giving rise to a very, very prominent anterior meningeal artery or the anterior calcine artery, and the ophthalmic artery is continuing distally as a very, very prominent supraorbital and supratrochlear artery. Now, this is in anticipation of the time when this artery is going to get completely occluded. So at that time, when the entire ICA gets occluded, you will have a pathway, nature will have a pathway to bring blood from the extracranial circulation, that is from the extracranial superficial temporal artery branches via the supratrochlear artery into the ophthalmic artery and then into the ICA territory. At the same time, you can see that the anterior meningeal artery has become very prominent, and we know that when the anterior meningeal artery is prominent, it already has lots of anastomosis with the middle meningeal and the posterior meningeal. So this is again another example of a collateral system which is developing in real time. If we were not to intervene at this stage and we were to do an angiogram after 6 months or after a year, we will see that this has progressively narrowed and this has progressively taken over. The same patient posterior part, since the ACA is not filling from above, from below, that is because of the steno-occlusive lesion of the terminal ICA. What is happening is the posterior circulation, this is the posterior circulation injection, this is the anterior circulation injection. In the posterior circulation injection, you can see that that is the pericallosal artery, that is the pericallosal artery, and this is an anastomosis between the so-called anterior pericallosal artery and the posterior pericallosal artery, which is a part of the posterior medial carotid system. So again, a situation in which you are seeing lots of collaterals happening between the leptomeningeal vessels. These collaterals are happening at the posterior callosal levels as well as at the cortical levels. So this is an anastomosis between a deep perforator system and the leptomeningeal system. This is an anastomosis between the leptomeningeal system of the PCA to the leptomeningeal system of the ACA. So all these kinds of anastomosis also do exist. Sometimes in a patient with an ischemic stroke, whenever you have, let's say, a basal artery occlusion, a proximal vertebral artery occlusion, or a distal IC occlusion, nature itself has sent you with collaterals. So this is a condition in which you have a persistence of a prominent anastomotic channel in between the anterior circulation and the posterior circulation. This is much below the PCOM. So this people is basically a persistent trigeminal artery. So sometimes instead of having collaterals just at the level of the circle of Willis, you can have collaterals below the circle of Willis between the two primitive channels, which persist and which may give you an out in cases of carotid occlusion from below. This was a patient in whom the carotid was completely occluded. Patient had a TIA-like feature. When we investigated, we find that yes, the patient had a carotid occlusion, but at the same time, the patient had a persistent trigeminal artery that was taking care of the distality, and we did not have to do anything for this case. Now let us come back to the case that I showed you, the case of the young gentleman who had pulses weak on the left side and who had an occluded carotid and vertebral on the left side. This is the carotid angiogram of the right side, and this is a vertebral angiogram of the right side. What you are basically seeing is not just from the vertebral artery going up is the vertebral artery coming down, but in between, at each segmental level, you are seeing these connections between the two vertebral arteries. So these are the segmental arteries. What is important for us to understand is we are vertebrates. Vertebrates means our entire body is made in segments. Each segment is a complete segment which is derived from a somite, and each somite has a sclerotome, a myotome, and a dermatome. So basically each segment will have skin, will have soft tissue, will have bone, will have its own vessel, and will have a contribution to the meningeal component at that level. So when you have these 5 things together, it is called as a metameric segment. So now what we have to understand is these vertebral arteries also develop as segmental arteries initially. So what you are seeing here as anastomotic channels between the two vertebral arteries are basically the remnants of the segmental arteries. And what we find as a very fascinating vessel in the adult is basically not a segmental artery, but it is a connection or a joint segment of the intersegmental arteries. So the vertebral artery in itself is not a developmental artery, it is not a phylogenetic artery. It is basically a connection, segment number A, segment B, between these two, intersegmental connection, intersegmental connection, intersegmental connection. So what is basically happening is in the adult, the intersegmental connection remains and the segmental vessels either are too small or they involute. But if they are small, they can be recruited in situations like this to reform what has been occluded from below. This is how, therefore, the vertebral artery has been reformed on the left side. And when we look at the carotid, again, the internal carotid is not a embryological vessel, it's not a phylogenetically developed vessel. It is again just a conduit. But the external carotid artery is a part of the metameric system. So from the external carotid artery, you are seeing branches which are basically going to the thyroid, the superior thyroid artery, which is dividing into 2 branches going across the thyroid and then subsequently reforming the ICA, the CCA bulb on the opposite side. Let us see the angiogram. You can see it much better now. You can see that in the late phases, the entire vessels are being reformed, and similarly, when we see on the other side, you can see that these thyroid arteries are also going to the opposite side, and they are also, the intersegmental vessels are also reforming the carotids. If you look a bit more, another interesting part, we saw 3, 1, 2, 3, 4. We saw 4 segmental arteries. We saw segmental artery number 1, segmental artery number 2, segmental artery number 3, segmental artery number 4. But when we look at them more carefully, we realize that all these segmental arteries are not in the same plane. There is a concept, there is a metameric concept which says that the medialmost part of the somite, which is called as a sclerotome, which forms the bony elements, it splits into 2. So you have the notochord in the center, which is going to form the neural tube later, which is going to induce the neural tube. So you have the neural tube in the center, and you have 2 somites on both sides. So the sclerotome is the medialmost part. The sclerotome has to move medially and enclose the entire neural tube. So when it encloses the entire neural tube, what it does is, it brings its segmental supply also, and it keeps one segmental supply which is anterior to the vertebral body, and another segmental supply which is posterior to the vertebral body. And that is what we are seeing here. In fact, if you see this is the anterior view, this is the AP view. In the AP view, you can see that there is only one vessel which is anterior to the vertebral body. We go to the lateral view. In the lateral view, we again see that this is the vessel which is anterior to the vertebral body. But the rest of the connections, you can see, are posterior to the vertebral body. So now, we go to the posterior view. In the posterior view, the anterior intersegmental artery is not very clear, but the posterior intersegmental arteries are very clear. And if we do a laminectomy, we remove all the lamina, then we see that these are actually plastered on the posterior part of the vertebral bodies. So this in addition tells you that apart from the known connections which can reform these vessels, if the ischemia is chronic enough and if the demand is high enough, you can have almost all the embryological structures that can grow and that can contribute to the reformation of the circulation of the brain. Segmental arteries in the spine up to the clivus follows a metameric model. So in situations, for example, in a case in which the left ICA is completely occluded, you can theoretically have connections between the right and the left ICA up to the clivus level. I'm talking about infrabilism. This is a situation in which the meningohypophyseal trunk, the dorsal medial clival artery, meets the dorsal medial clival artery of the opposite side, and it is attempting to fill the internal carotid artery which is occluded from below. So this same pattern can be seen at multiple different levels. Yet another case in which the clival artery is trying to go and fill the vessel on the left side. So coming back to that case, why did that patient have a subarachnoid hemorrhage? Obviously, because the circle of Willis has to overcompensate for decreased flow on the left side, lot of flow through the ACOM. So this patient ultimately ended up developing an ACOM aneurysm. He had an ACOM aneurysm as well as a double fenestration of the ACOM. So this was treated very simply just with a flow diverter. We did not balloon coil this for the simple reason that this entire structure, this entire segment is dysplastic, because this entire segment is under a lot of hemodynamic stress, and we do not expect the hemodynamic stress to go down. So just balloon coil would have strengthened only the area which has ruptured. So we decided to put in a flow diverter and reconstruct the entire vessel. Just one more important. Yeah, I'll just take half a minute more. So left ICA occlusion, robust circle of Willis, good perfusion to both sides. So in the past, we used to use the venous phase, not the arterial phase. We used to use the venous phase to see if the venous phases of both the hemispheres are coming at the same time. If they are coming at the same time, we say that the perfusion is good, and then we do not take the patients up for intervention endovascular. We keep the BP up and do all the medical management. But if the venous phase is delayed, then we know that something has to be done, even though the patient has a low NIHSS right now. Now we have parametric imaging. With parametric imaging of the same case, we are able to demonstrate that, let's say you take two similar points on both the hemispheres, and if you can demonstrate that the arterial filling is happening at the same point of time on both the sides, in that case, we again do not push these patients for an intervention. We tend to treat them conservatively. If they deteriorate, then definitely yes. If there's a collateral failure, then definitely yes. So I'll stop here. We have been able to map out each sulcus and the arteries on each sulcus, which ultimately are able to make anastomosis between ACA, SACA, MCA, PCA, ACA, PCA, and ACA to ACA. So all these things, and this is a composite model that we have developed. Last slide. What I believe truly is the future of endovascular interventions is not the mechanical ability to open an occluded artery, but rather a pharmacological ability to engage and make the existing collaterals more prominent, so that we don't have to do a plumbing job, because we already have natural bypasses at so many levels. Maybe in the next 5 to 10 years we will be able to see this. And with that, I'll stop. I welcome you all to Patna on the 5th and 6th of September for our Patna course, which is a biannual course, and where we will be discussing this and much more. Thank you for your attention.